welcome to our Zoomers as well. And we're here today to, as I say, it's the best bit of the year because last year we all had the pleasure of reading about people's planned adventures, like a plan for a novel. And today we get to see what happened. And we're we welcome you all here, and we welcome some parents and friends and family and everything who are here as well to our lovely rooms. So we've got five presentations. Four of them will be done from here, and one of them we hope, with the magic of technology, can be done from home online. We'll see how it goes. Each speaker has given us some slides to put on, and they have 10 minutes to talk to us, and then I have it open for 5 minutes afterwards for questions. And after that, we can all go and have some pizza and catch up and ask some more questions. So I'd like to, first of all, the running order is Rabia first, and then Jessica. Yeah, Jessica's here. Yeah, and then Matthew. Yeah, and Neil. And then we've got Natasha, who's online, I hope. So if I'd like to welcome Rabia to come on up and talk. Does anyone need the loop? Would anyone be helped by the loop, or we can just leave that one out? Yeah, okay. So over to you. Welcome.
Thank you. Hello, everyone. My name's Rabia, and I'm really excited to be here today to be speaking about my elective that I did in Pakistan. Sorry, it's not going to be good.
This one.
Oh, okay. I was doing.
Yeah.
Oh, perfect. Thank you. So I spent 6 weeks at the Memorial Christian Hospital in Sialkot, Pakistan. It's the oldest hospital in Sialkot, and it was established in 1886 by the Christian community. It's a private hospital, but it has much lower fees than others in the area, in line with their mission statement. It's a 350-bed general hospital, and it has services in ophthalmology, cardiology, family medicine, and more recently, inpatient physiotherapy. And last year, around 8,000 babies were born there. I spent time in obs and gynae, pediatrics, and general medicine. So a bit about the city of Sialkot. It's one of the most important industrial cities of Pakistan, and it's sort of known as the football manufacturing capital of the world. And it even produces the World Cup footballs, which is pretty cool. And I've also included an image here of the famous clock tower in Sialkot. So why Pakistan? So I chose to undertake my elective here because I wanted to experience healthcare in a different environment, experience more rare conditions and different presentations that than I'd see here in the UK. I can speak in Urdu, and I wanted to use this to consult with patients and also develop my vocabulary further to communicate more effectively with patients from a South Asian background when I came back on placement here. So I'm very passionate about health promotion, and before I went on my elective, I did some reading around the more common infections and conditions in Pakistan, and was surprised to learn that Pakistan has the second highest number of Hep C infections globally. So I created these patient information leaflets in both English and Urdu, aided with images for patients who aren't able to read, to give to patients, and they found these very beneficial. And my supervisor also asked me to print them out in poster form to put around the hospital. And I've also brought some along with me that I can hand out at the end. So focusing on the more rare conditions I saw, so in pregnancy, women presenting with seizures and loss of consciousness who were diagnosed with eclampsia, acute flaccid paralysis due to polio. So though the incidence of polio has decreased due to free vaccinations, there are patients who live with the long-term impacts of this, and there's a dedicated team of physiotherapists to help with their rehabilitation. Extrapulmonary manifestations of TB. So an example is a 17-year-old patient presenting with distended abdomen and fever. Initially, when I took a history, I thought this might be a more gynecological problem. However, following an acidic tap, the patient was diagnosed with abdominal TB. Also, many pediatric patients were admitted with nutritional deficiencies. These included iron deficiency anemia and dehydration as well. So what I learned was the impact of having no routine screening program. So especially in pregnancy, blood pressure isn't routinely monitored, which means that unfortunately eclampsia is quite a common presentation, and there's even a dedicated room on the antenatal ward for eclampsia patients. With financial constraints, resources are diverted to managing medical emergencies with less focus on preventative health. Pakistan has the third highest number of children under 5 in the world suffering from malnutrition. I wanted to see whether there were any sort of food fortification programs. So until recently, there hasn't been. However, Nutrition International is an organization that has implemented a large-scale food fortification program in 56 districts across Pakistan. Pakistan being a low-income country means that most people buy their buy from small-scale mills rather than large-scale ones. And there's also been a pilot to support 10 small-scale mills to fortify their flour. So I was able to undertake consultations in a different language, and I found that many of these focused on educating and counselling patients. An example is a 10-day-old baby brought in by mum with reduced oral intake. When I took a history, I learned that the mum wasn't aware of how to breastfeed properly. I was also able to pick up on clinical signs such as murmurs due to rheumatic fever. I was surprised to learn that the level of health literacy is quite low. I did have an idea of this sort of beforehand, but I don't think I appreciated the full extent, and especially for patients who live in rural areas with limited access to resources. Unfortunately, some topics are still considered to be a taboo. These include breastfeeding, postnatal depression, mental health, and menstruation. Women often rely on their female members of family to teach them about these topics, and if they don't have them, there's no way of them learning correctly, as there aren't any formal health visitors like there are here in the UK. And therefore, healthcare professionals play a vital role in opening up the discussion around these topics. So Pakistan has a largely paternalistic model of care, which is very different to what we have here in the UK, which raises sort of issues surrounding shared decision-making and patient autonomy. In the clinics that I was in, 2 doctors would share a room and they would see patients at the same time with no sort of dividing barrier or anything, which of course raises issues with patient confidentiality. And bad news was also broken in this setting, which I did find quite difficult to see at times. So I wanted to use a case study to further highlight the impact of culture. So a 3-year-old boy presenting with a 2-day history of pyrexia and tonic-clonic seizures. The parents had initially taken him to a local hospital where he was bathed with cold water and put under a fan, and they tied a black thread around the patient's ankle. And when I asked the mum what this was for, they said it was believed to ward off the evil spirits that were causing the seizures. And when they saw the patient wasn't improving, they brought him into the Memorial Christian Hospital. So what I did in this situation was take a focus history and examination. And with my supervisor, we and following the blood test that the patient had, we concluded that the most likely cause of the seizures was febrile seizures. So I took time explaining to the parents what this meant in patient-friendly terms. And what I learned from this was how there are many different factors which all contribute to a patient's health. This includes the home environment, societal pressures, superstitions, cultural beliefs, poverty, and education. In Pakistan, you can have up to 3 or 4 generations living in a home, and priority is often given to the elderly members of family, which can delay if children need to see a doctor, it can delay their presentation. And therefore, health education should be embedded into every interaction with a patient in a non-judgmental manner. Here's a list of my references. That concludes my presentation. Thank you so much for listening. I've also included images here of a weekend trip I went on. There's an image here of the Faisal Mosque and some pictures from Murray as well. Thank you for listening.
To the floor. Yeah, I was an obstetrician, and I was impressed by the size of the unit. 8,000 deliveries is bigger than either of the units in Leeds, as you know. And I got the impression that there's no antenatal care. And are there home deliveries so that they do it because everyone from the hospital to have a baby?
The question is, sorry, I'll just tell them on Zoom. The question is asking about home deliveries and obstetric care experience.
And so I was from what I saw, and I think in the past probably there were more home deliveries, but now patients they travel up to 2 hours to come to this hospital if they are having a baby to deliver their baby. And the sort of mode of delivery as well, it differs. So here in the UK, from what I've seen on my obs and gynae rotation, they encouraged women to go for vaginal delivery. However, in Pakistan, I think one of the doctors said 8 out of 10 deliveries are C-section. They sort of request cesarean in there, which I found, yeah, quite.
Paul.
Thank you so much. Really great presentation.
Thank you.
Right then, I love the leaflets, by the way, very colourful.
Thank you.
Contribute something there. I was just about the taboo subjects as well, breastfeeding. How much of that meant that women don't breastfeed, or what's the instance of breastfeeding, effectively from a psychiatrist about mental health? Did they have a liaison psychiatrist service?
So, to answer both questions. So first, breastfeeding. The doctors are actively encouraging women to breastfeed and are teaching them about the importance of this, as sometimes they do hold back. And I did see around the hospital there are posters now for encouraging breastfeeding and teaching them about the benefits of breastfeeding. So I think it is being more openly spoken about now from healthcare professionals' side. But I think I'm not too sure how it is in the home environment. I think women now, if they are aware of the importance, so if they are being told to breastfeed, then they will, because as I've said, it's sort of quite paternalistic, so they do follow what the doctor says. Yeah. And then going on to the psychiatry and mental health, I saw a patient who had come in with what I sort of thought to be postpartum psychosis. However, it wasn't really picked up on, and I did ask whether there are services that they can be directed to or signposted to at all, but it wasn't something that is sort of known there. And the focus is more when somebody presents with psychosis or any mental health condition such as depression, that because of Pakistan being an Islamic country, that to sort of advise them on praying or sort of take sort of that side. So I did find that quite different to see. Yeah, but yeah, to answer your question, there weren't any liaison psychiatrists. No.
Sue?
Just to ask you, it's very interesting presentation. You're doing three different weeks.
Yeah.
So which do you think out of it to go back or go and have that and do that subject as a future occupation?
So the questioner asked which week was the one you'd go back to of the 3 weeks you were there.
Profession.
So I enjoyed all 3 of the different rotations. However, I think what I sort of enjoyed most, I'd say, was the pediatric rotation, just because I saw sort of children of all ages. It gave me the supervisor I had for that rotation was really helpful, and he taught me a lot as well. And I got to see, so during that rotation, I saw an example of a really encouraging supervisor. And not to say that the others weren't, but on obs and gynae, I had a different experience. So I'd say for that reason, I'd go back to the pediatric rotation.
So final question.
Yeah. Yes. So this hospital, it was sort of established by Christians, and a lot of the staff members there are Christian. However, they do have Muslim doctors. I think they're the sort of the main the other sort of main religion. I didn't see any friction. I think most of the staff members, they worked well together, and all of the patients that presented, they could be Christian or Muslim, and they'd receive the same care. So I didn't see any sort of problems arising from that.
And final question.
What do you think you can then bring back over here, and how's that can change the way you're primary students and junior tops?
Yeah. So I think this experience, I learned a lot. I think the main thing being, or one of the main things being, the importance of understanding and sort of educating patients and understanding things from their perspective. I think sometimes Even here in the UK, we can assume that patients have sort of a baseline level of knowledge, but this isn't always the case. So I think it's really opened my eyes to really asking and understanding how much the patient knows, and then tailoring my care and my response to how much they know, not sort of, it's not a one size fits all approach, to really understand and empathize with the patient, I think is the main thing. Thanks.
Great.
I could give out some of the leaflets that if you'd like to have a look.
Thank you very much.
Everyone, my name is Jess, and for my elective, I went to Cambodia and I did a community healthcare elective. And I've titled it Recovering from the Khmer Rouge 45 years after it happened. So this is just quickly what I'm going to cover. So just a bit of context about Cambodia, if you're not aware, it's a country in Southeast Asia in between Thailand and Vietnam. It's got a rich, long history of amazing food and amazing, there's a national wonder of the world there called Angkor Wat, but it's also got quite a dark history that not many people know about. So about 45 years ago, there was one of the largest genocides of the 20th century, called the Khmer Rouge. And what happened was so after the Vietnam War, a radical communist party came into power in Cambodia, and this was led by a man called Pol Pot. And during this genocide, they killed a quarter of the entire population of Cambodia, including women and children. Now, half of that, so about 1 million of that was due to famine, and 1 million of that was due to murder, basically. So the whole point of the sort of regime that the Pol Pot decided to do was he wanted to make the country an agrarian society. So he wanted the country to be predominantly farmers. He thought that this was a way to help the country recover after sort of what happened on the back of the Vietnam War. And the people that they murdered, they targeted intellectuals. So they killed people that were teachers, anybody that was educated, could speak a different language, doctors, any healthcare professionals, even people with glasses, because they deemed those people to be smarter than the others. So you can tell how intelligent this regime was. And due to this 45 years ago, it led to so many long-term challenges that still affect the country today, including landmines. They put landmines all over the country, and that still causes massive issues now. A lack of healthcare, still lack of education, and there's still severe poverty and famine. It's still a third world country. So just a side note, in terms of the landmines, if you look on the maps on the left, this is where the landmines were previously. And if you can see the ones where there's a lot less red, that's the landmines now. So there are still a lot there, and these cause lots of disability and death still in the country now. Whilst I was in one of the villages, a village down the road, there was 2 people that unfortunately died due to farming, and their farming equipment went over one of the mines and they unfortunately died. So it is still a massive problem. But one of the ways that the country is trying to sort of get rid of these landmines is they use rats. And if you can see, I'm holding one. I thought it was so cute. They use these rats they're really sweet. I know they're terrifying, but they're really sweet. They use these rats and they send them into the sort of places where they think there's landmines, and the rats go and sniff out these landmines. They're trained to detect TNT, and then the people go and safely explode them and remove them. So that was just a side note of a place that I went to go and see these cute little rats. So for my actual elective, I went with a charity called Build Your Future Today Centre. They're a very small NGO who are trying to help Cambodia recover from the Khmer Rouge. So it's founded by a man called Setalong. He's the one in green. He's actually a genocide survivor. He was 14, 15 at the time of the genocide. And he managed to survive, although his family unfortunately didn't. He made his way to a refugee camp in Thailand. And whilst he was there, as he was an educated man, he strived to teach everybody else in the refugee camps things that people didn't know about already. So healthcare, different things. And since then, he's made his life goal to try and help Cambodia recover. So I went and helped with them. They do lots of different things. They've got a healthcare section, which obviously is what I went to do, but they also do other things such as business planning. The whole goal is to make villages self-sufficient, so they don't need to rely on NGOs and charities, because obviously it helps now, but they want them to be able to do it for themselves in the future. So whilst I was there, I predominantly did two different things. So I did teaching and I did sort of healthcare. So in terms of my healthcare teaching, we drive about 3 or 4 hours on dirt tracks to villages that were very much rural. A lot of them didn't have access to healthcare. They didn't have much electricity. They had a generator that they could use when they needed electricity, things like that. So they were quite on their own, really. So whilst we were there, we sort of did lots of things that we thought they'd kind of benefit from. So we did a lot of basic life support, CPR choking, because as you can imagine, if somebody was choking in a village that's 3 hours from a city, it would be quite a devastating thing to occur if they didn't know how to get rid of that, or, you know. So we did a lot of that. We also did a lot of family planning. So we taught a lot about family planning, because a lot of women, sometimes they don't have any contraception, and death during childbirth is quite big there. So one of the charity's aims was to go and give sort of coils that would last 5 years, which would mean if they didn't want to have children, they could have a coil, which meant that they didn't have to see a doctor for 5 years. And it was sort of a long-term management plan for that. We did a lot of dengue and malaria prevention sort of teaching, because a really interesting part is I was in a village and we were teaching a room full of children, and I said, how many of you have ever had dengue? And about 4/5 of the people in the room put their hand up. So it's so prevalent out there, and they didn't really have much knowledge of how to prevent it. So we did a lot of sort of mosquito prevention, things like that. Teaching about water sanitation and sort of general hygiene for the children, such as teeth brushing and things like that. So we also did a bit of community healthcare. So a lot of the times we did wound care. So we'd go into schools and villages, and there'd be a lot of children that had a lot of wounds. And a lot of the time we'd have to do sort of myth busting on wound care, because it seemed like they didn't have much education on how to prevent infections and things like that. I mean, a lot of the children, when they got a wound, they'd just smother it in toothpaste and sort of leave it. So a lot of the time it was sort of myth busting on not to do that and what to do. And then at the end of the day, we'd sort of do like this little makeshift clinic in a school and sort of fix up their wounds, which you can see I'm doing there. And a lot of health care checks. So just general health checks. A lot of the villagers wanted that for us. So that's what we did. This is just some photos of me out there. So the photo here is me and my other placement partner. And here we're teaching school children on, you know, not drinking, not smoking, sort of things like that. Here's a photo of us learning what we're going to talk about on the 3-hour bus car journey to the village, because we had a lot of spare time whilst we were driving. And yeah, that's just one of the entrances to one of the schools. So just in terms of what I learned, so this is just a photo of my host family whilst I was out there. They were lovely. Learned so many different things. I mean, I learned so much about teaching and public speaking skills, because we were talking to a whole village at a time. Every time we'd go there, the chief of the village would bring the whole village, and we'd be teaching in a room of so many different people. So that was very interesting. A lot of knowledge about tropical diseases. I don't think it's taught very well, at least not in our university. So I learned a lot about dengue and malaria that I didn't really know much about before. And yeah, I guess sort of a larger worldview. I mean, I didn't know much about Cambodia before I went out, so that was amazing to go out there and see. That is everything. There's just some photos of me whilst I was out there. This is Angkor Wat, the place I was talking about earlier. There's some bugs that we ate. And I don't think you can see in the little corner, but I was just doing a little plug. This charity is such a small charity. They've only got 10, 20 medical professionals that are sort of related to them, and I really want to spend a lot of time with them in the future, and I want to go back. I'm trying to get people to know about them and go there and stuff. So yeah. There's my references. That is everything.
Well, Susan.
Interesting. I know absolutely nothing about Cambodia, and I certainly
No, I
think
didn't.
it knows all these problems. We two questions. One was, is there an alcohol problem? Since you were talking to the children about drinking, and also, presumably you were doing this through an interpreter, or
Yes. So the first question, yeah, so alcohol problems there are huge. A predominantly large problem. I mean, I'm sure you are aware of the Lao distillery problem that happened recently and the tourists that died from the alcohol. That is also a really big thing in Cambodia. They make a lot of their own alcohol, and then because it's not filtrated and stuff, a lot of people die, and that unfortunately does happen there a lot. And the nurse that we were traveling with say that children out there, they start drinking really early on there, so that's why we were going and teaching the dangers of alcohol. Yeah, we had an interpreter. Everybody in the charity speaks English. They speak really good English, and the nurse also spoke English, so we were kind of telling her what we were saying and then she'd translate it. So it was challenging at times, but it worked. Yeah.
Sarah, and then Jim.
Yeah, very interesting presentation, thanks. So I just wondered about the vaccination programme that they have over there, or does it exist?
Yeah.
So our question asks about the vaccination programme.
I'm not actually aware. I'm not sure. It was never mentioned. There was never any mention of any sort of vaccinations, but I'm assuming that they do probably do them. I mean, I know that the charities go out and they give vaccinations, but I'm not aware if there's like a national programme for the people out there. Probably have to look that up, but it was never mentioned. But they do have big general hospitals in the cities, like in Siem Reap and Phnom Penh. So I'm assuming that maybe they have them there, but it's all privatized out there, so I'm assuming maybe you have to pay for it. But again, I'm really not sure. Sorry.
Thank you. Jim.
My question was going to be the same, that what language we're speaking, but just to move on from that, was Cambodia ever part of a kind of European empire? Burma was. I asked because you mentioned about students now not being taught very much about tropical diseases. They used to be, when the British were going out there, and the empire, its sun never set on it. But is there a country that has had responsibility in a way, like France, for example?
I'm not too sure. I mean, when I was in Vietnam, it's very obvious that the French were there. I mean, there's a lot of French influence in Vietnam, whereas in Cambodia, there didn't seem to be any sort of Western influence. I mean, their sort of language is completely different. The way that they write their language is completely different. So I'm not entirely sure, but there didn't seem to be much Western influence. But again, I'm not too sure. Maybe have to look that up.
Andy.
That's very interesting. Then you live with a local family. How did you find that? Was it very different to your normal experience?
So, oh, sorry.
The questioner asks about what it was like living with a local family.
Yeah, so most of the time I lived in a hostel, but I visited the host family pretty much every day, and it was very different. I mean, Cambodia is a very deprived place, and the host family that we stayed at a lot of the time, they lived in like a big wooden house, but it was really high up. There was like really high stilts, and it was like, and I don't know why. And I kept asking them why they lived in a house with such high stilts. And I said, is there a lot of water? Like, is there flooding? And they said, no, and I'll never know. I'm not really sure why. But I found in Cambodia, they are so generous and so welcoming. And every time we went to their house, they'd cook us these massive meals all the time, and they'd take us out on little trips. I mean, they bought us bikes for us so that we could go out and bike with the family and stuff. They were so generous. But yeah, it was very interesting and quite a different experience to the UK.
Vietnam, despite its sort of 20th century major issues. It's a very forward-looking country. Is Cambodia the same despite what happened under Pol Pot? Do they dwell on that, or do they seem to be more sort of proactive and forward-looking?
Yeah, so do you mean, do they still sort of,
You'd imagine that with genocide going on, somebody's going to perpetrate all that, and
yeah,
you've got survivors, and
yeah,
together after
of
that
course.
horrible history.
Yeah, so it felt quite strange there because it was so close by. I mean, it was only 45 years ago. It wasn't long at all. It's every single person I met knew somebody that had passed away through the genocide. So it did feel like it was still something that was very heavy, and it was still very important to everybody in each family because every single family member had somebody that they knew that suffered from it. But yeah, I think there are a lot of challenges, and it does show in Cambodia. I mean, even in Siem Reap, you know, one of the biggest cities, you see a lot of people that are on the street and homeless, and they're missing limbs because they've, you know, unfortunately suffered from landmines and stuff. So it is quite a heavy country because there is all of that still going on, and they are still suffering from these challenges. But it seems it's very upbeat there. And I mean, there's so many tourists that go to Cambodia now, which is amazing. Like there's such a big sort of backpacking community there. So I think they are getting there, but it is quite obvious when you go that there is a lot of problems that still, you know, haven't been resolved since the genocide, I suppose.
Amazing presentation. That was a really specific question. Yes. Who, if you said that the hospital is private, who owns the wealth in Vietnam? Are they Pol Pot's generals? Is it the agrarian community?
Who owns the wealth? Yeah.
Oh, I was thinking because I want to go to Vietnam.
Yeah.
Sorry.
I really don't know. I mean, it seems from my experience, all the places that were a little bit more wealthy were sort of foreign companies that had come in and brought in sort of all the backpacking hostels and stuff were all owned by outside places and things like that. I mean, I really don't know. It's hard to sort of trying to think. It's a difficult question. I'm not sure. Yeah.
Don't worry, that wasn't it.
Yeah, no, sorry. Yeah.
I'm just amazed.
To think.
I think that really struck me is a totally different relationship with rats. And I just want to clarify something. They're not sacrificing themselves and blowing themselves up. They're finding.
Yes.
So no rats were harmed in this.
I'm gonna say that actually. So a landmine will only be set off by a certain amount of weight, and these rats are kept on a strict diet. They're weighed every day to make sure that they don't go over 2 kilograms, because over that they're at risk of it happening. So they're always under 2 kilograms so that it never happens. And yes, they've never lost a rat to landmines, and they're very they love that.
Thank you very much. Thank you. And I'm gonna do my presentation. So if you can go on. I did my elective in 2 areas. I'm going to talk about the first part. I did in area called Kerala, which is a region in India, and I did it at Mitra Hospital, and I mainly focused on neurology, stroke medicine, and hypertension clinics when I was there. So I chose Kerala because I have a personal connection to the area. I trace my heritage from there, and most of my family still live there. So I've got a quite close connection to the area. I speak the language, so luckily consultations weren't too difficult. It's got an interesting blend of a kind of well-established healthcare system which uses modern evidence-based medicine, and there's quite a huge, significant alternative medicine market where they use Ayurveda, homeopathy, and other alternative medicines. Ayurveda is a kind of a traditional system of medicine that originates from India. It's very popular. In fact, in the area, there's actual 4-year, 5-year degrees where they study it, and the doctors are qualified and they're called doctors, even though it's a totally different thing.
It doesn't have a very strong evidence base, and they have been found to contain some of the treatments prescribed under them have been found to have high levels of heavy metals and other dangerous, harmful things. Growing up, I often saw members of my family and friends in that area using kind of alternative medicines. And when I was young, it didn't really bother me. It just thought there was some ointment or something. But kind of when you're old and your uncle tells you he's no longer taking metformin, he's taking some plant that his cousin told him to take, it gets more worrying. So as I picked Gala because I wanted to introduce more evidence-based medicine. I wanted to build confidence in that. And I kind of want to inform people about the risks of these kind of things. So I had this kind of initial idea of doing leaflets on the risks of unproven Ayurvedic remedies. And I talked to doctors in the area, and they actually told me, don't do that. It's going to be perceived as really insensitive. Despite the fact that I trace my heritage from there, because I'm kind of coming from a foreign country, which once colonized that country, it would be kind of not perceived very well. And when I thought about it and thought about the patient view, I decided let's kind of shift the focus. So instead of doing that, I thought to kind of understand why patients are reluctant sometimes to take on evidence-based medicines, modern medicines, and kind of build confidence rather than knock out their traditional practices. So I talked to a lot of patients as part of this. I wanted to bring this case study actually because it was something I saw a lot, but in one of the hypertension clinics, I met a kind of middle-aged elderly patient who had poorly controlled hypertension. He had actually been poorly controlled for a while. His family and his doctor wanted him to take amlodipine and regular medications, but he didn't really want to. He was relying on kind of a herbal water. He wasn't very keen to make the switch. During kind of discussions with him, it became apparent that he was quite fearful that kind of a medication made by Pfizer or some other company would have dreadful side effects, and he trusted these health medications. And as I talked to him, I kind of realized, yeah, I guess why, because he's seen his family members use them and live quite long lives. So gradually, I kind of began to understand why a lot of patients didn't take modern medication. So a lot of them had this fear of side effects. And I found out one of the biggest things that spread this fear of side effects was WhatsApp. It's a really big, it's really popular for news and media in India. The amount of times I've shown some image or forwarded messages that were going around in circulation, but things like that, there was a big fear of side effects. There's also a limited awareness of certain health risks. So for a lot of chronic conditions like diabetes and hypertension, they've appeared more recently with the adoption of kind of more sedentary lifestyles. They don't have as many people who've had it. So for some people, they're having it for the first generation. Their parents didn't have it. So it's a new thing. There's also a bit more of a distrust of the healthcare system compared to the UK, because more of the healthcare system in Kerala is privatized. So it's a mix of public and private. So they do sometimes fear that there's corporate interests involved in prescribing. And finally, things like cost and accessibility. Homeopathic and Ayurvedic treatments are cheaper and they're often dispensed directly. You don't have to go to pharmacy, so they just feel a lot easier. And people have known them for years, so they just feel more reliable. So based on this, I kind of began developing materials to help promote confidence in evidence-based medicine. And I tried to focus them around what a lot of patients had complained about, what they felt uncertain about, things that they were less sure of. And with that, I kind of used the iterative process. We sat with patients and discussed their fears, and we also were able to discuss what they understood. So I redesigned the pamphlets to make it, initially I kind of wrote a bit too complicated, and then I was like, okay, let's simplify this and make it a bit easier to understand. During the focus groups, I also gained some new ideas. So a lot of people speak English there, and nearly everyone can read and speak English, but I was told it might be a good idea to make something in the native language. So it's on the side, because a lot of the older patients and even the middle-aged patients kind of trust media that's written in their own native tongue more than English language. And the other thing was I used a bit more digital media. So by making it WhatsAppable, it's a good way to kind of combat the misinformation. I think my attitudes were really changed because initially I'd gone in with a bit of a view to tell people about how to take the medication or do what they want. But I realized that that doesn't really help, and viewing people as kind of not sensible, it doesn't help. So I moved from kind of directing patients towards collaborating with them. I think that was very important to improve therapeutic outcomes. I think coming back to the UK and having done placements in areas like North Lincolnshire where their health literacy is far lower, I can see why it's important to always be able to communicate with patients, be able to reach out and bridge a gap in understanding. Because obviously after 5-6 years in medical school, you develop a lot better understanding than the regular patient does. I think also the other thing I realized that's quite useful and important is that the UK is becoming increasingly diverse, and some people practice different healthcare practices to what we know. So it's important to be able to understand them and work with that. So I did the second part of my elective in Bac Mai Hospital, which was in Vietnam, in Hanoi. I chose this because it was a public hospital and it was provided quite a big contrast from the UK and even Mitral Hospital, which was a lot more resource rich. And I want to see how poor hospitals manage things differently. One of the things I was really shocked by when I went to Bac Mai Hospital is that I'd never seen before in the UK, but there were 2 patients sometimes on one bed, quite a few times. So, and yeah, we have a lot of overcrowding here, but I'm yet to see 2 patients in one bed. I've previously did the intercalated degree in management, so I was interested to see the kind of the impacts of having to deal with this level of overcapacity. When I was going to the management team, I found out they're actually well above capacity, so they slowly went from 100% to 120, 150% in the aftermath of COVID. So they're now seeing much more patients than they have room for. I was interested in the impact, and with a doctor, I kind of learned about how it's increasing the rate of ICU and healthcare infection rates, which is obviously causing a cascade of issues because more patients are staying longer, and it's putting even more pressure on the hospital. I was quite interested to learn about international collaboration at Bac Mai. So to manage these challenges, such as high rates of ventilator-associated pneumonia, they've collaborated internationally with people outside. So I found about a collaboration with Japanese experts where they introduced a big VAP 10 item bundle, and by increasing compliance now, they were able to really bring down rates of ventilator-associated pneumonia. So I found it really interesting from how international collaboration has been able to target some of the challenges they face. Reflecting on kind of what I learned in Vietnam, I think one thing I definitely gained a great understanding for is kind of this struggle of kind of resource poor environments, because it's not just not having access to resources, it's how the lack of access compounds issues, making patients stay longer and increase rates of infection between patients. I think the other thing I really learned was that it's a lot harder doing clinical skills when there's 2 patients on a bed. So there's a lot of honing and adaptability that I kind of gained from doing it. And I think that's going to be useful in the NHS when I'm in FY1. Thank you for listening. And photos. That was.
Questions for Matthew? So if I start at the back first and then move forward.
Thank you very much for your presentation. Sharing beds was a massive cause of TB in Britain right up to the 1920s. Food housing used quite a lot. Was there a high infection rate of TB in Vietnam?
I'm not sure about TB actually. I noticed that there was a lot of respiratory infections that could probably easily spread if patients were next to each other. Because even in like a lot of the wards it was there. I remember when first time I saw it was in cardiology. But I'm not sure about specific diseases.
Was that generally true of Vietnam? You didn't see many patients with TB.
I didn't see I was more in kind of cardiology, acute care, and things like that.
Can you put your hands up again? So if you go to there and then Matt and then Jim.
I was wondering, this is more of a specific question, but you mentioned you found it difficult doing clinical skills. What sort of things did you do whilst you were there? Like, what were you allowed to do in the hospital with a student?
In fact, mate,
The question is about what your clinical experience was, your clinic was able to be in Vietnam.
So kind of the initial ward rounds, we would also examine patients afterwards. And we kind of did take part in that and so we were like taking part in, and kind of practicing similar skills to the also just going from one end of the bed to the other. So not so much left hand side, right hand side. I didn't take blood so much, but yeah.
Yeah, your presentation. Canada is famous for literacy level.
Yeah.
Some of the health beliefs.
I was quite surprised by this actually, because even like some doctors would like use alternative medicine. I guess things like Ayurveda have been there for centuries and centuries. So, and people are still kind of have a lot of faith in it. I would like to say a lot of patients do go to both doctors. I think also even here, like we have people who like take supplements which might not have very good evidence bases, but often, you know, some people go and get treatments and they just feel like it's not working, and then they want something which might have a bit of a miraculous cure rate or something from the practitioner. But it is quite popular. I was surprised as well, even kind of in more educated communities.
Jim.
Thanks. I have two comments and a question, but my question has already been asked about the fact that Kerala has a reputation for being so much more well versed in medicine and much better statistics in maternal mortality, for example, really spectacular differences from the rest of India. So I was also interested in the fact that it was working in spite of that enlightenment, as I see it from Kerala. I had a comment about Kerala, which I've forgotten, but my only other comment. My only comment was that Malayalam is an answer in today's Times crossword.
I was going to mention, even though it's quite well educated, I was surprised because there's actually like government-backed institutes where they teach these kind of alternative medicine, like homeopathy, and like people go and study that, and they're allowed to call themselves doctor, even though here, like you're not just Mr. or Miss or whatever. Yeah, it's true.
So, Sue.
When you're sitting in your clinic years ahead, and you've got all this medicine there, medicine still hasn't got the answer to everything. Certainly, I'm thinking gynae. I used to toddle off to Holland and Barrett and read all the leaflets and see which I could then go back and tell my patients about. Because, so I'm really now, I feel like it's not certainly some of the conditions in gynae and capable periods, all sorts of things. We haven't got the answers for any of these. So I think actually your medicine, if you'd gone to that country and sort of said, right, we're going to get rid of the Ayurveda medicine, I think it would have been, we could use that.
Yes, many. It's a nice presentation, first of all. And I think you're so fortunate not to see patients underneath there. I think the Asian countries did in terms of epidemic and you're not just sharing beds, but you have to deal with that. So you're so fortunate. I don't think, what do you really think that why this high beta influence rates in let's say Vietnam? Is there a good gatekeeping mechanism so that patients can be set up in like in GP system like in
Sorry, come again.
Yeah, can you? It's difficult to hear the question.
Yeah, what my question is like why this high patients turnover, like so much patients in like you have to share 2 beds in Vietnam.
Right.
Oh,
yeah.
If this
I heard.
Yeah.
I heard that Back May Hospital is very popular. A lot of people like come from quite far, like even from one of the patients I saw in acute care, like come from 2 hours away or something. They'd been sent to Back May. So I think I don't know if that hospital, so they were like the big tertiary center that the capacity to treat a lot of things which smaller hospitals in the area couldn't treat. So I don't know if that also contributes where people actually want to go there because that's where they'll get the best care.
Just the distribution. No. Okay. we have a really nice system that we reach the GP, and then from there onwards, the patients are filtered and sent to the care level. So, but in almost all the Asian countries, does not have a very clear system where, I mean, if you can go to any secondary patient care hospital, just bypassing the primaries. So the most popular hospitals, almost all the time gets over.
Yeah, our questioner makes the point that there's no sort of gatekeeper or
I think
primary
I
care.
think they also had some private referrals too, actually, in back May.
Jim,
Who has reminded me of what my other comment was. And you said that patients were reluctant and anxious about taking amlodipine. And it just reminded me of when I was put on amlodipine. I was very worried about the side effects potentially. And I had made the mistake of reading the insert, the package insert, so it was a particularly irrelevant comment. But
final comments for you, Matt.
Again, sort of following on Sue's comment, what you talked about was we've got evidence-based Western medicine, whatever we think, strict evidence-based and IBD, which has a very long history but doesn't have the published trials of it. But if you think about what the motivation is for doing those studies, either it's big pharma who are investing in new medication, or it tends to be public funded use of cheap medication. How would we get to a point where there is space for against IBD? Because not having evidence doesn't mean it doesn't work, does it?
Yeah, I think there is some trials and things being funded in it. I was thought like with something that's evidence-based, it's when they kind of found something in there has some, and a lot of it is something, I think a lot of it is kind of plant-based things and things. So I don't know if Pfizer will pick up some plant-based treatment and find, oh wait, no, that if you isolate that compound, you concentrate enough, it does do something. So I'm not sure what I think it's whenever you start seeing results from it.
And maybe also evidence-based changes. I'm old. The OX2 inhibitors coming in as I think it was going to solve pain for us because having people died of it. So evidence shifts and changes.
I think maybe also if there's more regulation kind of brought in, because there is kind of like there's quite high levels of like heavy metals in some of these high-risk medications. So we need to there needs to be some kind of something to regulate it. So at least people, if they want to take it, can take it safely.
Right, we just had a little bit of activity cleaning up in the background. Antique table. Thank you for talking through all of that in the back. Thank you very much for your follow-up.
My name's Neil. Thank you for allowing me to come this evening to talk about my elective. So for my elective, thank you. There we go. For my elective, I self-organised a medical elective based on a 6-week programme covering trauma and orthopaedics. I've chosen today to best deliver my experiences in the form of a reflective presentation, in which I hope to reflect on the development of my attitudes, my knowledge, and also my skills. My elective itself was split over 2 sites, one in the UK and one in Vietnam. And the objectives of my elective were split over 4 main components, really: to become integrated into a surgical team, and not just in terms of a medical student profile of observing, but to become more practical and more procedure-based, to enhance my surgical capabilities, and also develop procedural knowledge, and to develop an overriding intention to practice medicine and experience medicine in a totally different context outside of the UK. And what that meant was, by travelling to Vietnam particularly, was seeing the day-to-day practicalities of a cost-driven healthcare system. One there, I would hope to see, what the system exposes in terms of inequalities for those who gain and those who don't gain from the system itself. Okay, so first I spent 2 weeks within the NHS at Hull Royal as part of the trauma and orthopaedics team there, under the guidance of Miss Sally Hobson. And the majority of the caseloads that I observed and participated in were in terms of elective in nature. So these were knee arthroplasties, hip arthroplasties, soft tissue injuries such as carpal tunnel releases and also tendon transfers. And then also some stuff at Castle Hill, which was joint stabilisation procedures, so ACL reconstructions. However, alongside these elective procedures, I often frequented within the team and department itself based at HRI. So I had the fortune of spending the time with Mr. Symes in the virtual fracture clinic, reviewing cases at 6 and 12 weeks follow-up, and also experiencing the benefit of technology when it comes into play with seeing patients remotely, and also managing caseload. I also managed to become part of the plaster classroom for one afternoon and see the simple reduction of fractures. Commonly at the time during summer was distal radius fractures by young children playing in the sun. And I also got to spend some time with Miss Mulder, seeing the paediatric list there at HRI as well, which occurred once every 2 weeks. So pelvic osteotomy procedures and also tendon releases in children with cerebral palsy, which was wonderful really to see the straight away the increased range of movement and also quality of life, quite literally 2 hours after coming out of post-operative care. And also, I think as a young man, I wanted to see a lot of major trauma and was told by Miss Hobson not to get too ambitious really. I think Yorkshire itself sees 4 major trauma cases per million people per week, which in practical terms meant over the 2 weeks I'd see less than 1 case. And on the final Friday, before flying out to Vietnam, I got my opportunity. So I was shadowing the on-call registrar. A call came in for a red alert. That was a high impact RCT. So a motorbike had been knocked off. A motorbike cyclist had been knocked off. And I was involved in the primary survey, the secondary survey, was involved heavily with ED, and also had the opportunity to go down to limb reconstruction surgery with Mr. Muir and see the procedure and follow up as well in the days afterwards. So if I just move on and talk about what did I gain from my 2 weeks in HRI in terms of clinical skills. So I was able to develop on suturing techniques. So I was able, with Miss Hobson's fortune and almost good nature and convincing of the consultants to allow me to close, and I was able to develop and continue with simple interrupted sutures and continuous sutures, but also exposed to new suturing techniques. So subcuticular suturing for cosmetic appearance and also mattress suturing for areas of tissue under high pressure. I broadened my practical knowledge and theory of joint arthroplasty. So I was exposed to, by Professor Sharma, the benefits of posterior versus anterior approaches to hip replacements. And also during my time on the wards, spent with FY1s, with the majority of cases being over 65 years old and an aging population demographic, I was often given the opportunity to sit in and help document the practicalities and ethics of having an elderly patient in orthopaedics. So witnessing DNA CPR forms, respect form discussions, advanced directives. And I think that really benefits in terms of getting an understanding of the jobs I'd hope to frequency as a junior doctor. Yeah, in terms of knowledge, I think it was mainly brought about by listening to the junior doctors, well, resident doctors, sorry, who were there, and just having an opportunity to sit down at the end of the day and also integrate as part of the team. I think as a HIMSS medical student, you often go on and work deadline to deadline or go on and have an expectation to learn about cases and theories. But I think with the hours to sit there with the team and I was getting an appreciation for what the day-to-day life is of a resident doctor in respect to their core training role was absolutely wonderful. I got exposed to things like shift patterns, rotating hospitals within certain deaneries once core training starts, the different training pathways to achieving core training in orthopedics, so academic fellowships, or also core training pathways and specialty training. And I was also exposed and almost invited in terms of how to achieve a training place, almost welcomed and almost taken in like a sibling, I guess, to most of them. So I was exposed to surgically logbooks, teaching awards, national awards, and conference involvements. And these are all things that, since my elective and with the good nature of this experience, I've managed to provide my own clarity in terms of how best to go about a training pathway to achieve what I want to achieve beyond medical school. And a final personal highlight from it was actually invited into the research group that was based in HRI in terms of exploring the perceptions and preferences in undergraduate surgical education. And again, this will help strengthen my application. As we know, there's a relative bottleneck at the moment for competition places for all specialities. And I think hopefully it helps me going forward in the future. So yeah, that was my 2 weeks in HRI. I then on the Friday evening finished, packed up my bag, Saturday flew out, and on Sunday I arrived in Vietnam. I travelled over 6,000 miles, crossed 8 time zones and caught 2 flights which were nearly 28 hours long. And you can only imagine the revelation when I turned up to Backmire Hospital, turned the corner on the induction to see Matt tucked behind the door smiling and glaring at me. But it was a nice sight to see a friendly, familiar face. So yeah, at Backmire I spent 4 weeks again within the trauma and orthopedics department, But due to the nature and frequency of trauma that happens in Vietnam, I managed to integrate as part of plastics, general surgery, and also ED as well, when going down for primary and secondary service, and also when patients were arriving. I had the good fortune there to be part of two good educational supervisors, Dr. Zhang and Dr. Kong, who were regarded as senior chiefs of departments, which is effectively a senior consultant who sits on the board in Bach Mai. And both of those spoke great English and were often translators at times. So my days itself consisted of a completely different scenario to what it would be in the UK. Surgery over there is actually from 5 a.m. till 2 p.m. So at 5 o'clock in the morning, I would go to hospital and have the major trauma meeting, which was delivered in English with a PowerPoint presentation and a rapid ward round. And on the ward round, all the juniors and all the nursing staff would go round. So often you'd have about 36 to 40 people behind me on the bed, crowding around, listening to what Dr. Zhang and Dr. Kong were translating for me. So then at 5:30, theatres would begin and the list would continue to 12. And at 12, the list would stop. And the reason being was due to the temperature. It didn't have the capacity itself to function after 12 o'clock because during our times there, as sure Matt will know, it was 35, 34 degrees at 12 o'clock and unbearable. And they're the cases that I saw were a majority emergency caseload. So polytrauma, acute limb injuries, hip fractures from high energy trauma, traumatic amputations, acute compartment syndrome, pelvic fractures, compression fractures, and also open fractures with soft tissue injuries as a result of penetrating injuries. So what did I learn from my time in Bach Mai? And I think this relates wholly to my attitude. I think a completely different healthcare system as what I objected to achieve really changed my attitude to medicine, and how about I go about my practice today. So just a few points that I highlighted that don't really touch on everything that was there, but really show the depth of what goes on in a different country. So resourcefulness. So despite Bach Mai being a tertiary centre for the North and considered one of the best, it severely lacked resources. So in theatres, as you can see, in the top left, there's a manual tourniquet. And this had to be pumped up every 30 minutes because it was actually leaking air. The second picture relates to, so there's only actually two lead line jackets between the 14 theatres at Bach Mai. So every time there was an X-ray, sterile staff and theatre practitioners would scurry out and they'd all gather around behind that overturned lead table. And, I found it quite funny because they'd all scurry back in and back out. But I think for them, it was a relatively normal thing to do. But amazingly, the lack of resources didn't really dampen the mood. There was, it often bred ingenuity. So as you can see with the third picture there, Dr. Zhang would what I call create his own Meccano kits out of odd bits and pieces in the room. So that there is a arthroscopic ACJ joint reconstruction surgery. And the actual tension for the tendon is being maintained by a 1 litre bottle of hand sanitizer that has been tied to two rods which were taped together. And at times afterwards, I'd always, not really be pleased with Dr. Zhang at all and Dr. Kong, but they'd always smile back and say, "Don't worry." And often, yeah, it worked and they were pleased. But as I said, it was amazing to see, and for them, it was a normal thing to do. In terms of resources as well, healthcare practitioners were rationed. So there was one anaesthetist for every 3 patients in theatres. So at times that meant that nurses were independently delivering perioperative assessments and also intraoperative monitoring independently. And often you wouldn't see an anaesthetist for maybe 20, 30, 40 minutes whilst they'd be floating around between 3 or 4 theatres. Yeah, and the overcrowding also spilled from the wards into the theatres. So towards the end of cases, 2 cases would be occurring in one theatre. So a registrar or one of the other students from the local area and myself would be asked to close. And Mr. Kong and Dr. Zhang would actually be preparing the next patient in the opposite corner of the room, which was quite amazing to see. I think the other thing to touch upon is teamwork and camaraderie and resilience. The actual staff there both work both on the ward and in theatres, worked long hours in demanding conditions, and actually found out they worked for very, very little pay. The nursing staff, HCAs, physiotherapists weren't really a thing over there, but they always had a constant smile, shared lunches together, and invited me to their homes at the end of the day. And I think that kind of teamwork and motivation was what really got them through the day, and some of the things they saw in the cases they experienced managed to achieve the outcomes they aimed to because of that bonding as a group of people. And I think finally the last 2 points on there really highlight the effects of a private healthcare system. So Vietnam has a private healthcare system in place. public healthcare is in place, but it covers only those of an extreme of age. And with regards to private healthcare, approximately 80% in the north, 80% of the people in the north actually had private healthcare. But it was often those with the 20% without the healthcare who presented to hospital with the most complex of conditions and the worst prognosis from the trauma they experienced. There is a healthcare team on site. I've just got it on the next slide, so I'll flick forward. There was a healthcare team on site who would, as you can see here in the bottom right, a healthcare team on site who go round and assess each patient in turn. Okay, assess each patient in turn and try and see if they can support them. But often at times they wouldn't provide everything to everyone, and it was quite heartbreaking to see, particularly coming from the NHS and seeing care delivered on an access need or access of clinical need rather than ability to pay. If I just quickly run forward because I'm conscious of time. I think the other things to appreciate were the public health promotion in the UK and national legislation. So the majority of these cases that were coming in were the result of motorbike legislation being extremely poor, unregulated driving styles, and also the density of a city like Hanoi, almost having a concoction of effects. Poor industrial regulation led to injuries of industrial accidents. Relaxed tobacco legislation actually contributed to incidental findings of malignancy on X-ray. So often patients would come in with an orthopedic problem and leave with two. And also poor water quality was an incidental thing that I discovered that led to most patients having bladder stones that would actually come in with and weren't aware of. And also to pick up on was the inverse care law. So the principle that care is least accessible to those who really need it. As Matt said, sometimes there are patients who are 200 kilometres away travelling to back mine. That was because in a private healthcare system, you can obviously go to the highest point of access as a first point of care. So the caseload itself was always difficult to keep up and maintain. And I've picked up on dignity in a similar way that Matt spoke about it. So they were operating at a 2-to-1 top and tailing scenario, and preoperative examinations and also intimate examinations would take place on a ward in front of everybody without regard for the principles that we respect here in terms of personal space, confidentiality and general respect. And holistic care, I've talked about it here, just because that picture in the bottom left, patients in Vietnam attend hospitals not by themselves, but with their total family. So the entirety of a family will often come and assist them. And families will sleep on the hospital corridors. At night, they'll set up makeshift kitchens in the car park as meals weren't provided. And so when you're liaising with patients and getting time to discuss with them, you have to approach it with the HIMSS approach, as I say. So the ideas, concerns and expectations, not just only of the patient, but also the extended family. How will they recover? How are they getting home? How have they financially afforded to be here? So what I'm quickly run through it because I'm very aware of time, but what have I done since coming back from the elective? So I've managed to deliver my experiences as a volunteer CTF, so clinical teaching fellow, to phase 1 students at Hull Royal Infirmary. I've delivered talks on orthopedics and general surgery, so drawing on some of the cases and experience I got to see over there. I had the good fortune of being invited by GPSOC to deliver a presentation on how to organise an elective, the practicalities of how to send a message to an organisation, what funding you'll need to apply for, how to get the most out of your elective, and how not to let finances restrict you. I think that was wonderful to see. And to my knowledge, I know at least one person now is returning to back my next year or this summer. So I can say I've had a good impact. I managed to attend some congresses with the team at HRI and also assist in the FRCS exam under Miss Hobson's guidance and help out with the assisting and running of that at HRI this year. And I think generally it's had a great impact on my practice in terms of day-to-day appreciation for what we have here in the NHS. I think I will never take for granted, the service and the value that it provides to its people, particularly over there where healthcare is a privilege and it's also a rarity to see good healthcare delivered. I just want to finish on this very briefly. This was me a year ago. I'd worked 7 days at Morrison's in Hull up until the run up to Christmas. I did 104 hours and set a record doing nights. And the reason being, I think, I don't think many of the people were touching it, or I was a bit afraid to touching it, but it was going in as a 4th year student into a 5th year student. It's very difficult financially. And maybe people are afraid to admit it, but I certainly won't be. I think when you come to 5th year, you don't have as much of a bursary or a loan. The academic demands mean that it's very difficult to get jobs in term and also balance the academic requirements. And so I can honestly say, without the support of the grant, I probably wouldn't have gone to Vietnam. So I'm very grateful for everybody here for reading my application and supporting it. And I can honestly say that it's been a wonderful experience. It's had a great impact on my medical practice and me personally as a person. So thank you.
Have any advice and questions? Andrew.
Hi, thank you so much for that. Comment on the question really. We like to talk about lead aprons of my medical lecture back in 1977 when I went to Nepal. And I got in touch with the hospital before I went, the mission hospital up in the hills, and said, is there anything you'd like me to bring out? They would say chocolates or some sort of thing they were missing from home. And they said, well, yes, actually, there is. We'd love you to bring out this lead apron. Bang went half my luggage. And then taking a lead apron through the scanners at the airport to the interior of the car. Extremely interesting. A flash out. I'm presuming we look big for it.
Yes, yeah. it didn't scare me away, no. Some of the trauma, like I said, I think as a young person, I wanted to go and see some proper trauma. No disrespect at all. I did see proper trauma, and I think I took a liking to it, truthfully. And I think that was heavily influenced by Dr. Zhang and Dr. Kong getting me heavily involved, and like I say, not just having me as a fly on the wall, but you know, come on, Neil, come and scrub in, come and see what it's about, be part of the team, and also feel the pressure. Really, was what they said. They talked about, you know, we went for a drink just before I flew out, and he said, before you become a good doctor, become a good person. And it kind of hit me. This is Dr. Zhang and Dr. Kong's life. They deal with trauma every day. Not a lot of people survive in Vietnam because of the nature of the incidents. If you can be a good person whilst delivering good care, it will help you achieve good outcomes and also make the thing more enjoyable and probably progress you further in your career.
Just a comment. You mentioned the high incidence of bladder stone due to poor water quality. You mentioned that frequently. I am engaged in reading the minutes of this society starting from 1832 and moving on to the end of the century. And I've been struck by the frequency of bladder stone in children and in various women, various adults, and I've been baffled to why like this. So I think you give me the answer.
Got a final question.
Well, was there any attempt to collect data on orthopedics? Is there a Vietnamese answer to Briggs and getting it right first time and starting?
I approached him on doing an audit or potentially a quip over there, but unfortunately, due to being there for a short period of time, what they deemed, and also there was quite a lot of legislation in place. So I think I was quite fortunate that Dr. Zhang and Dr. Kong allowed me to do the practical stuff. So I wasn't able to do any research over there, but I'd have liked to. But I think they're heavily involved and they do heavily publish with, I think, the Japanese and also the French students. There's like an exchange program that they do a lot of research with.
Matt.
What really struck me was a lot of your description about the value of a student being completely embedded within that team. And you know, certainly I recognise that from my days as a student. I'm sure all my colleagues will not in the room. But I think it's something aware that people don't experience it the same way nowadays as students. So reflecting on your experience, what's the barrier to you being that embedded with a team tomorrow at York or Scar? And you described in that elective, that is where the value is.
It was nice. It sounds crazy, but it was nice at the end of the day to not go home and have to revise, and also have the opportunity to not be taken off the board during the day for a teaching session or a seminar or whatnot, and stay throughout the 9 till 5, and then also say, okay, as a group of staff, we're all going so and so. If you come along, I think that really was a massive bridge of trust. Really, they got to know me a lot more, not as a medical student, Neil, but Neil as a person who likes to play football, go and watch a rugby, or have a few pints with Dr. Zhang after a day. I think it really broke down the barriers that were there, almost of going from a formal student to being almost a colleague.
Lovely. One final question to you.
The engineer. Fascinating. does it kind of inspire you to go into that field and innovate new equipment within the UK?
I have to be honest, probably not. No, I was quite scared to be honest the whole time during the procedures of like one, breaking the sterile field because it all collapses, or two, it just not holding the tension. But no, it was good fun to see, and hopefully it inspired some people and other students who were there to hopefully maybe go down that route.
Thank you very much.
Thank you.
Inviting me today to do the talk. I'm very sorry that I'm not able to make it in person. So I'm going to be talking about my elective that I did in paediatric cardiac surgery at the Royal Children's Hospital in Melbourne, Australia. My presentation is quite clinically focused, so a little bit different to the other presentations that we've seen today. Okay, so firstly, I was just going to take you through an average week of my elective. So in the morning, I would start at 8:30 for the ICU rounds. I'd then go and do the cardiac ward round, and then I would head to theatre at about 10:15-ish. And the cases in the day would range from about 2 hours to 12-hour cases, depending on the complexity of them. We also had multiple meetings throughout the week. One of my favourites was on a Thursday at 9:15. We had the JCC, which included doctors, the cardiac surgeons, the cardiologists, the intensivists, the perfusionists, and the anaesthetists as well. And they would just discuss complex cases that were in Melbourne on the wards, but also other patients around the country that were going to get flown into Melbourne, and also from other countries around. So we had some patients being flown in from Indonesia and, for very complex procedures. So outside of the busy ward days and being in theatre, I got to go every Wednesday to the Queen Victoria night markets with the other medical students that were on their electives there. We enjoyed some great food here. And on the weekends, we got to do some road trips. I got to explore Melbourne and the local area, see some of the local wildlife, and attend some of their footy games, which are just bizarre. So in terms of learning opportunities, the team, I integrated really well into the team, and they were very welcoming, and they could see that I was very passionate and enthusiastic about paediatric cardiac surgery. So I had a lot of discussions with the fellows and the trainees, as well as the consultants, which you can see by some of the drawings from these discussions. So a lot of the teaching took place outside of theatre, because during the cases they'd be very focused, and it's quite, serious. So you can ask questions, but you have to be careful of when and where. So the top right photo, I don't know if you can see my pointer, this is me scrubbed in theatre. I also got the opportunity to practice my surgical skills, not in theatre, but outside. They gave me some instruments and materials so that I could practice as well. And some of the fellows would show me how to do different anastomoses with balloons, which was really interesting. So I thought I'd just go through a couple of the interesting cases that I saw. So over my time there, I saw 33 cases in theatre, and I managed to scrub in on the majority of these, mainly as the second assist. So that would mean I would maybe do some retracting or some suctioning. I also got to see some chest openings in ICU, and this is just amazing. So in an emergency situation, they had the capacity to turn an ICU room into basically a mini theatre. The whole scrub team would come, they would drape the patient, they would open the chest and do whatever they needed to do in an emergency situation, which I'd never seen before. I also saw 6 patients going on to ECMO. Some of my favourite cases that I saw included an arterial switch operation, which is in the top right corner, which is used for transposition of the great arteries. And something else that I saw that was a bit different. So on the cardiac ward rounds, we saw patients with a Berlin heart, which is a ventricular assisted device. So the diagram here, if you can see my pointer, this is how they work. So they plug into the heart and they basically act as the pump for the heart. And they sit externally out of the body. So you can see this is the patient and these are the pumps. And you can actually see the pump working and the blood going through, which to me was just kind of mind-blowing to be able to see this. And they on the ward would have about 3 or 4 patients on this, as it's a bridge to transplantation. I was also very fortunate to be able to get involved with research. So one of the professors, Igor Konstantinov, so he's a prolific publisher and very well renowned in the field of pediatric cardiac surgery. And he took me under his wing. And what we did is he had a lot of surgical videos. So what I did was I edited these, narrated them, and created case reports. Two of them have already been published on the MMCTS, which is the European Association for Cardiothoracic Surgery, their like multimedia platform. And we've got 3 others which are in the peer review process, which is really great. That definitely was a new skill for me as well, like learning how to edit these videos, which is something that I can use in the future. And then continuing, having left, from my elective, I'm still in close contact with him and the team. And one of these cases we submitted to BISMIX, which is the British and Irish Society of Minimally Invasive Cardiac Surgery. My abstract got accepted and I got to do an oral presentation as part of the multimedia competition, and I was very fortunate enough to win this with a case where we looked at atrial septal defect closures via a partial lower mini stenotomy. And this opportunity has now given me the chance. They're funding me to go to Istanbul for the International Society of Minimally Invasive Cardiac Surgery's conference next year, which is just amazing. And none of that would have come about if I hadn't gone to Melbourne. And going on from that as well, I've got some abstracts, video abstracts, which have been accepted at the SCTS, which is the National Cardiothoracic Society Conference in the UK, which I'll be presenting later this year, which is great. So I thought I would take you through one of the case reports that I did, and one of the cases that I saw. I warn you, this has got surgical video, so I'm going to talk about the intricacies of the case. I hope no one's squeamish. So I'm just presenting a 14-year-old patient who presented with severe aortic stenosis. They had a postnatal diagnosis of a bicuspid aortic valve. You can see this on the right. So the right coronary cusp and the non-coronary cusp were fused together, and the left coronary cusp was separate. So the patient presented, went to MDT, and it was decided that they would undergo a balloon aortic valve dilation. This is how this is done. It's done in the cath lab. It's not done as an open procedure. But unfortunately, this resulted in severe aortic valve regurgitation and insufficiency, which is an emergency. So the patient was then 3 days later brought to theatre for an aortic valve repair. So a midline stenotomy was done to expose the heart, and this is the view that you have on opening the chest, opening the pericardium. So the patient was then put onto cardiopulmonary bypass. So the aorta was cannulated, the SVC was cannulated, the IVC was cannulated, and then an aortic cross clamp was applied and cardioplegia was given to arrest the heart. Next, once the patient's heart had been arrested, we opened the aortic root so that we could see and clearly visualize the aortic valve. That is the left coronary cusp that has just been shown, and this is the fused right and non-coronary cusp. So we're looking down into the aorta, and here you can see where the leaflets have been torn from the balloonplasty in the cath lab, and this is what's given the regurgitation. So next, what we needed to do was do an annuloplasty. So basically a Gore-Tex suture is passed around the aortic root. You can see here it's gone underneath the coronary artery, which was sat along here. And what this does is it tightens the aortic roots to help bring the leaflets closer together to help prevent, I don't know what I'm supposed to help them move together closer. And what we do is we put a Heger dilator into down the aortic root so that we know the exact size that the annulus is going to be. And then this is secured with knots and a tie and a clip. So next, what we're going to do is we need a patch to repair the aortic leaflets. So what we did in this case is we actually took part of the ascending aorta, the wall of this, to create a patch. So here we're cutting it, and this is part of the aortic wall. We measure the leaflets using a silk tie, and then we cut the patch of the aortic wall to size, and then this is carefully sutured into position. Firstly, this was done on the fused right and non-coronary cusp. As you can see, it's quite deep, so technically it's very challenging. This is a lot faster speed than what's done in reality. So it's very mathematical in terms of looking at the correct size and how it fits within the leaflets. This process is then just repeated for the left leaflet. You can see here. And then what the surgeon will do is assess how the leaflets come together and coapt to hopefully make sure the valve is patent. So next, because you've taken part of the ascending aorta, what you need to do is stabilize the sinotubular junction. So basically the root of the aorta to connect the ascending aorta to the root. So what we've done here is we've used a Gore-Tex graft to do this, and this is just the closing and end of the procedure. So after the procedure, the patient is weaned off the coronary pulmonary bypass, and then they're transferred to the ICU, and this patient recovered well. What I'll do is just show you the preoperative and postoperative echoes. So this is a parasternal long axis view. I really hope you can see my my pointer. So on the left side here, this is the preoperative echo. This is the left atrium. This is the mitral valve here. This is the left ventricle, and this is the aortic valve. You can see here from the Doppler that there's just free regurgitation with every contraction through the aortic valve. And what we can see here on the right, postoperatively, you can see actually the two leaflets of the bicuspid valve coming together and there being no regurgitation. I hope that's clear. And then this is the same, but just in parasternal short axis view. So on the left is the preoperative. You can see here that the leaflets aren't coming together clearly without the color Doppler. And on the Doppler on the left, you can see that there's just color, there's just free regurgitation. Meanwhile, on the right, postoperatively, you can see clearly that the two leaflets are actually coming together nicely, and you can see the line forming. And then you can see on the right with the Doppler that there's no regurgitation. So what was the significance of this case? It's technically challenging. It's innovative in the patch selection. So they're using the aortic wall, which hasn't been done before. Previously, you use homographs or treated pericardium. And this is actually an alternative surgical approach to the Ross procedure or a TAVI. And the main aim of this is actually, hopefully, by using living tissue, the patient won't need to have any further surgical reinterventions, which a lot of pediatric patients that have surgeries as neonates and as they get older will have multiple surgeries. So if we can prevent that, then it's really brilliant. So just to reflect on my time in Australia, you know, it was the warmest winter I've ever experienced, very different to a winter in the UK. But aside from that, in terms of medicine, it was very different to see the differences between the UK and Australia, just in terms of like weather, work-life balance, culture. And in terms of pediatric cardiac surgery, it really gave me the realization of, you know, what the training process is like, how long the hours are, how demanding it is physically and mentally when you're looking after very sick children. And, you know, some of them are coming from difficult situations. So ethically, actually, there's a lot of debate and when to treat patients and when not to in some of the very complex lesions. It was very interesting to be able to spend the time with and integrate with that. And kind of along the lines of what Neil was saying, being able to spend all day, every day for a consistent amount of time with the same team, you get to really integrate and you feel like you're not just a medical student sat on the side, you're actually getting involved, you're participating in the discussions, you're discussing treatment plans, you know, you're looking at the surgical approaches and you can really kind of weigh in and get a better appreciation of what it's like to be a surgeon in this field. And also get to appreciate more of the patient side because you spend more time with the patients. You'd see the families on the ward every day. A lot of the patients will be in the hospital for months on end, especially if they're having multiple procedures. So you see them every day. You get to know the families and the kids, which is something that I've not had the opportunity to do before. So some of the take-home lessons for me would be just the importance of teamwork and good communication, especially within the MDT. They work with doctors all around Melbourne and Australia and even internationally. So the level of communication and within your own team, especially on highly complex cases, is very important. And it's also highlighted to me the importance of research and advancing medicine to help improve patient care. So firstly, I'd like to thank the incredible team at RCH for getting me really involved. I had an absolutely brilliant time and I would recommend anyone to go back there. I've helped a few other students actually organize their electives there as well this year. So it was a brilliant opportunity. And also thank you to York Medical Society for making this possible. It's very expensive to go abroad and to Australia as well. So yeah, you guys really made it possible for me to go there and have a great experience. So thank you very much. And yeah, I'll take a bit loud outside, but I'll take any questions. If I stop sharing. Maybe.
Thank you, Natasha. So we'll take some questions if you like, and I'll repeat them to you. So Jim Drive.
Could I ask, how common is it for the original balloon dilatation to go so badly wrong?
So the question, if you caught it, is how often is it that the balloon dilatations go wrong?
Yeah, so it's difficult because if you think when you're doing the balloon dilation, you can't actually see the leaflets of the valve. So it's very hard to gauge if one of them is caught, if you're going to tear, if not. What was actually interesting in this case, so this was done in a 14-year-old. Normally, the balloon dilations are actually done in neonates or a lot younger children because they can withstand the regurgitation better. And it's used kind of as a step before surgery to try and make sure that the child is bigger and stronger so that they would be able to withstand, you know, a major cardiac procedure. So in those instances, it's a lot rarer. I think they were really toying with the idea of whether to go for the balloon dilation, but I think this consensus was that we can try it, and in the worst case, we take them to theatre. So rather than having to go for the extreme intervention first, we'll try and go for a slightly less invasive approach, and then we'll go for surgery if we need to. But in terms of the age group generally, and in terms of adults, I think it's not as common for it to, it's just a complication really. It's a risk of doing a balloon dilation. I hope that answers the question.
Question there?
How's the 14-year-old doing? Thank you very much for your presentation.
So the question is, how's the 14-year-old doing?
Yeah, they're doing really well. So they did the operation while I was in Melbourne actually, so I saw this one. And from my understanding, they came off the ICU well. They were on the ward for not too long. I think they were on the ward for about a week. And then they've gone home. Yeah, so what they will do is they will continue the care at their local hospital. So pediatric cardiologists will keep reviewing the patient, and this patient will probably be monitored for life or until they become symptomatic, and hopefully they won't become symptomatic and we've cured, you know, their aortic stenosis. But with bicuspid aortic valves, there is a risk of stenosis, and unfortunately this patient experienced that at a younger age.
Question from Paul and then Andrew.
Thank you so much. It's actually for that amazing presentation with all the graphics and videos. A few years ago, I spent some time as a junior doctor in Australia, in Sydney and Cairns. And you mentioned culture there. So could you just tell me, when you said there's differences between UK and Australian culture, what would you say were the main areas of difference?
So the question is about what the differences you found in culture between being in Melbourne and being here.
Yeah, so I think different culturally in terms of being in the hospital, so hospital teams and their approaches. For example, I found the team very welcoming. Not that I haven't had good experiences in the NHS, but I just thought generally people working in the hospital, so it was a public hospital, were a lot happier. They, you know, they managed to get off shifts on time. They had better support. And in terms of like the consultants and the training, it was very different compared to pediatric cardiac like surgery that I've seen in the UK. I've been in Birmingham and I've been in Southampton. And actually just speaking to the fellows and their experiences, they're just saying, you know, they started at 8:30 and their shift would finish at 5:30 if they weren't on call that day. In the UK, you would have to do the ICU round, so you would have to be at the hospital at about 5 a.m. and then you would finish at about 7. One of the fellows was actually from Canada, but had done a fellowship in Texas, in America, sorry. And she would start every day at 3:30 in the morning, and she would then finish at 7 p.m. at night if she was lucky. So in that side of like being in the hospital, and you know, it's very different. But I think it's different all around the world in different trainings. And then in terms of just like the general life, obviously there's a big Aboriginal population in Australia, and there's a lot of divide between the Aboriginals and other people and the cultures and the differences there. Aboriginal populations, their healthcare, they're not looked after as well. And the studies that have shown this, even in hospitals like Melbourne, they'll fly people in from all around Australia to treat them to get the best care. But locally, when people then fly back to their homes, what care are they receiving? They're not receiving any follow-up. So that was different and difficult because that's not something that I've necessarily experienced, the health disparities to that extent as in the UK. And also politically at that time, there was a lot of kind of debate and stuff while I was out there.
Thanks. Final question from Andrew.
Yeah, great presentation. So as a result of your experiences, are you now destined to be a paediatric cardiac surgeon? And also, given the difference you just shown between UK and Australia, have we lost you to Australia?
Did you get that, Natasha?
Yeah, I did. So to answer your first question, I mean, I really like cardiac surgery. That's something that I'm very interested in, but I think it's also opened my eyes to pediatric cardiology. Is also very rewarding and very interesting area. I think for me, I'm very interested in anatomy. I'm very interested in cardiac anatomy. So pediatric cardiac surgery or cardiology is also the majority is structural lesions, which, you know, different vessels in the wrong areas and stuff, you know, I just find that fascinating. So, you know, in the ideal world, it's obviously a very challenging career, but that's something that I'd definitely be considering. Have you lost me to Australia? No, because what I would say,
There's lots of really, everyone's smiling.
What I would say is that one of the things that I didn't expect going out there, I'm fortunate that I've done a bit of travel before, you know, to Thailand and stuff, but I really felt the time difference when I was in Australia. So I could only call my family before I went to hospital, so, you know, at like 5, 6 a.m., or it would be 11 p.m. at night. And it's strange not being able to just, you know, text your mom or your friends, you know, during the day and be like, oh, I just saw this, you know, or what are you up to? Or do you want to have a quick ring, you know, before cases or something? You can't do that because of the time difference. And that was something that I didn't expect. Being very close to my family, I don't think I would want to move out there permanently because of that. But I would definitely do a fellowship. So I would definitely consider doing like a year out there or 2 years to learn and to train, but not indefinitely. Although most of the team there were from the UK. I think all the anaesthetists had trained here. So yeah, it's interesting.
Well, thank you very much, Natasha. As they say in Eurovision, really great show. Could you put yourself on mute? And I'd like to call up Matt to give our vote of thanks to all our speakers. Do you want to come up, please?
Good. Hi, good evening. So for those of you who don't know me, I'm Matt Morgan. I'm a member of the York Medical Society. I'm a trustee, but I'm also Dean of Hull York Medical School. So it's fantastic. As always, whenever I see any Hull York Medical students doing anything, I'm just blown away by how amazing our students are. And that, I really do mean that. I'd really like to thank Rabia, Jessica, Matthew, Natasha, and Neil, and brownie points for Neil for having his hymns tie on. Very good. They were fantastic presentations, all of them, and I think there were some really important common themes that were coming through all of that. The bits that really stood out to me was that you all in various ways talked about what you'd learned about the importance of teamwork and resilience and problem solving and making the most of the resources that you're working within. And whilst we often complain about, you know, the resources that we have within the National Health Service, we still need to take that step back and still be grateful for what we do have compared to what a lot of other countries are working with. The other bits that I think really came through in all of your talks was about the importance of patient-centered care and understanding your patient and their culture and their background and the importance of their family and working with them to come up with the right solution for them, not coming along and saying, this is what you're going to do and this is what's going to make you better. And I think that came through from all of you today. The final thing that I think really came through to me from all of your talks was just the joy that you'd all clearly brought back from your experiences of being really embedded with those medical teams and being involved in that hands-on delivery of care to your patients. And I hope that you manage to maintain that, retain it the whole way through your careers, because it really is what makes this career worthwhile. You know, that's certainly my feeling. And I think talking to my colleagues, that's pretty much the feeling of all of us that have been doing it for some time. I would also really like to thank the York Medical Society members, the contributions that have gone to funding these students to be able to undertake their electives. It's so important that our students get these opportunities to go and do these amazing things and have these learning experiences. And I think the phrase I'm going to take away with me from tonight is to become a good person before you become a good doctor. And I think that is such an important thing for all of us to remember. So thank you, Neil, for bringing that to us as well. So on behalf of York Medical Society, thank you all very much for coming and doing your presentations. On behalf of the medical school, thank you to York Medical Society for supporting our students. And I think it's probably time for pizza.